morning. I'd like to call the meeting to order. The Minnesota Senate Health and Human Services Committee. It is Tuesday, January 28th, 2025, and we do have a quorum present. We aren't taking any formal action today, but we do have a quorum. Today we have a lot of presentations on the agenda to go through governor's budget proposals. And so I'm looking forward to hearing from, we have it kind of broken up into, the first part is related to Minnesota health licensing boards. We have the second part about the Minnesota Department of Health, and then last we have the Minnesota Department of Human Services. And so we will go through these areas. I think the budget proposals are described in detail in change pages, and Anna had sent out the link to the website where all of them are posted for you to review, and then a couple of the Department of Health and Department of Human Services have a presentation and slides today. And so we do have quite a bit of information. The final budget language is not with us yet, and so we will be getting that later on to be able to really study these proposals in depth. But for now, we wanted to get through a review of the proposals at a higher level, find out where we have more questions and we'll need more information over time. And hopefully members have questions today. You can ask about proposals that if they don't have the information with them, that it will be something that they can go back and find out more. So first, let's get started with the health-related licensing boards. And first we have the Board of Dentistry. Bridget Anderson is the Executive Director.
Excuse me.
Oh, yeah. And I'll just mention, Anna reminded me that in your packet, you do have the budget pages for some of these health entities. I think, are they all? Yeah.
No, just the substantive ones that are.
Okay, so the people presenting here today, you have the change pages for those. And welcome to the committee,
Thank
Ms.
you.
Anderson, and please go ahead and state your name for the record and begin.
Sure. Good morning, Madam Chair, members. My name is Bridget Anderson. I'm the Executive Director of the Minnesota Board of Dentistry. And I'm actually here this morning also on behalf of my colleagues at the other health-related licensing boards. And I have some with me today as well to walk through their specific budget items. So for those of you that aren't totally familiar with what we do, we are the Health Professional Regulatory Boards. There's 16 of us in the state here. We are considered executive non-cabinet, agencies. So we have our staff members and we also have board members that are appointed by the governor, and they're appointed in terms as determined by the boards. So our mission of our boards is really to make sure that the regulated healthcare providers in Minnesota have the necessary training, education, and skills to provide competent, safe, and ethical care. We do have common programs that are outlined in Minnesota Statutes 214 that you may feel familiar with, that also outlines our complaint processes that our boards follow along with our shared programs. We do have separate practice acts for our respective professions, and my colleagues here today will talk to you a little bit about the specific needs for their particular programs and boards. One thing that I think is important for this committee is that we are a fee-funded agency. So the Board of Dentistry, along with my other health licensing and regulatory boards here, we're considered independent agencies. So we are not funded by the general fund. We are funded, our fund actually lies in the Special General Revenue Fund, and as I mentioned, that's gathered by fees that we charge to licensees that are regulated under our particular boards. So we also, some of our activities include executive activities. As I mentioned, we're non-cabinet, but we are an executive branch agencies. And so we run as independent agencies with our organization process, things like that. We also have legislative priorities that we work with all of you, and thank you actually senators on this committee for authoring some of our legislation for our board. So we do bring forward policy items on behalf of the boards at times, and also rulemaking projects that you're probably aware of. as well. And we also have a judicial function, which it, deals with complaints, compliance, and also actions on licensees, depending on, what type of disciplinary action is pursued. And we also work with our administrative law judges in the OAH as well. So to dentistry, you do have it in your packet there. I do have a change item I'm bringing forward on behalf of dentistry. I do want to also point out to you that you see some budget changes in the dental budget over the last couple bienniums. And one of the reasons for that is that dentistry also houses the administrative service unit and the criminal background check program in our budget. So when you see some of those larger changes and you're looking at, I do have it described in there, but I do want to call your attention to the graphs because it may look like the budget just exponentially got very large, and that's not the case. I just want to make sure that you understand that that's differentiated in there with its own budget for that unit. The administrative service unit provides services for all 16 of the health licensing boards, along with the criminal background check unit. So seeing that in there. I do want to bring forward a change item for a new administrative staff position. The salary and fringe that you see there is about $100,000 estimated for both. For that new position. One of the reasons why I want this position is because I had to reclassify an administrative position for my complaint and compliance division. So really what I'm trying to do is reestablish a administrative position here. We do have over actually 300 complaints last year. They are becoming a little bit more complex in nature, based on just changes in dentistry and so forth. So I really would like some additional administrative support here. My current revenue does support this. I'm not asking for fee changes, so I'm really just asking for the appropriation and for you to support that for the dental board. So I'd entertain any questions that you might have on this.
Thank you. Members, do you have any questions? Senator Gruenhagen.
Well, thank you, Madam Chair. Yeah, thanks for the presentation. Just, my sister used to work for a dentist out in my area. Plus, I know a number of dentists out in that area. And one of the things is the low reimbursement for Medicaid as far as dental care is concerned. I think we used to be 49th in the nation. I don't know if that's changed or not. But do you have any comments as far as access for, because people on that have dental Medicaid, they're having an increasing difficult time finding dentists who will accept it. Do you have any comments on where that's at?
Ms. Anderson.
Thank you, Madam Chair. Senator, that's actually a good question for the DHS Medicaid program, the oral health division there. The Board of Dentistry regulates the profession, but that would be a really good question, I think, for that division.
Any other questions? Senator Udke.
Thank you, Madam Chair. Just a question of curiosity for when you talked about needing the extra help, and it's basically from the complex complaint type stuff that's coming in. Can you just give us an example of what is entailed in that?
Ms. Anderson.
Yes, thank you, Madam Chair. Senator, we've had a lot more complex cases related to surgical procedures, particularly implant procedures. And one of the things that involves is very complex imaging. And so in order to get the imaging in order and bring it to our committees and things like that, it's taking a lot more time and efforts to get everything ready for review for my complaint committee. So we do a lot of mainly complex surgical and implant cases. So that's where some of those additional complaints have arose from.
Senator Udke.
Thank you. That's all.
Okay.
Thank you.
Seeing no other questions, thank you very much for your presentation. I appreciate your
Thank you.
summarizing the board activities as in general too.
I appreciate it. Thank you.
Next, we have the Board of Behavioral Health and Therapy. Welcome to the committee, Samantha Strelo, is it? Please state your name for the record and begin your testimony.
Good morning, Chairs Wicklund and Utke and members of the committee. My name is Samantha Strelo. I am the Executive Director of the Minnesota Board of Behavioral Health and Therapy. That is a mouthful, so going forward I will refer to it as BBHT. Thank you for having me here this morning to talk about BBHT and our budget. For some background, the BBHT was created in 2003, and we regulate professional counselors, LPCs, professional clinical counselors, LPCCs, and alcohol and drug counselors, LADCs. Professional counselors are master's level mental health counselors who are employed in a variety of settings who provide mental health counseling services to Minnesota citizens. Alcohol and drug counselors provide counseling services to persons seeking services to address substance use issues. BBHT is requesting 2 change items that the governor included in his recommended budget. The first is an increase to our base budget to add a full-time position. Every year, the number of individuals we regulate continues to increase. In the last 10 years, the number of individuals we regulate has more than doubled. In 2014, we regulated approximately 4,000 individuals. As of the beginning of this year, we regulate almost 10,000 individuals. Each fiscal year, BBHT receives approximately 1,000 new license applications. With this growth, workload for staff continues to increase, which is why we are requesting this position. The board is currently collecting sufficient revenue through the fees we collect to cover this increase to our base budget. The second change item request is for a new fee. As you all maybe remember, last session, legislation passed that established Minnesota as a member of the Counseling Compact. The Counseling Compact allows professional counselors to apply for a privilege to practice in any state that is also part of the compact. The Counseling Compact is not currently issuing privileges in any states, but they do anticipate going live, so they do anticipate that they will start issuing those privileges sometime later this year. The compact language allows BBHT to collect a fee from individuals who reside outside Minnesota who apply for a privilege to practice in Minnesota. BBHT is looking to establish this fee and is requesting language that would allow us to collect up to $100 per application for a privilege to practice. I do want to highlight that the board plans to set that fee much lower than $100, likely around $25, but wanted flexibility to increase that fee as needed over time. This fee will be used to cover any BBHT costs associated with the Counseling Compact. This concludes my presentation. I just want to thank you for the opportunity to present today.
Members, do you have any questions about the Board of Behavioral Health and Therapy? Senator Abler.
Well, thanks. And I guess I'm okay with a fee increase, a new fee on somebody who wants a new thing. And the boards usually have a lot of restraint on their fee increases, and especially in these challenging times, I hope that all of them continue to be parsimonious on how much they ask their providers to give. So thank you, Madam Chair.
Any other questions? I'll just ask, with the establishment of the compact, is that, I don't know, do you have any updates or status on kind of how that's going and how you expect it to go as far as reception once it's implemented?
Senator Wicklund, thank you for the question. The compacts, and I'll speak about the Counseling Compact, but most of the other compacts that were passed last year, I think, are in this similar spot. That the compact commissions are working to adopt rules. Like I said, for the Counseling Compact and I believe the Occupational Therapy Compact, they are looking to go live sometime this year. The biggest part of that, which we testified to last year, is just establishing a database so each state can communicate with the central compact location to know who's eligible to apply for a privilege to practice.
Thank you. Yes, I don't see any other questions, so thank you very much for your presentation today.
Thank you all for your time today.
And next, we have the Board of Podiatric Medicine, Paul Bakken. Welcome to the committee, and please state your name for the record.
Good morning. Chair Wicklund, Chair Udke, members of the committee. My name is Paul Bakken. I'm the Executive Director for the Minnesota Board of Podiatric Medicine. We've been around since 1917, and the mission of our organization is to protect the public health, safety, and welfare of the Minnesota public by extending the privilege to practice to qualified individuals, to regulate continuing medical education, and to receive and investigate complaints against our licensees regarding their professional conduct. We have 2 groups of licensees that we regulate. On the one hand, we have our doctors of podiatric medicine. On the other hand, we have our POPFA licensees, which are prosthetists, orthotists, podorthists, fitters, and assistants. Yes, that's a mouthful. Nobody ever says the whole thing. We just say POPFA. In addition to that, we also have typically 24 temporary permits for people who are going through residency programs in Minnesota, and our fair share of professional firm registrations. We're here today to ask for your help and assistance and support in raising the authorized ceiling for our fees. The last time our fees were raised was back in 1999, back when the price of a dozen eggs was 96 cents. So as we all know, everything's gotten more expensive in the last quarter of a century, including all of the services that we contract through Minute, the Attorney General's office, rent, and personnel costs. As things stand now, we were doing okay up until about when the COVID peacetime emergency hit. At that time, our finances turned a corner. We thought it might have been a momentary blip, but it appears to be the new reality. As things stand now, we have a structural deficit of about $40,000 per year. In addition to that, our operating reserve fund, which ideally we would like to maintain at around about $250,000 so that we can draw on that during the year to support operations, has diminished to approximately $150,000. So if nothing changes, we will have depleted our operating reserve fund within 2 biennia. I could go on, but out of respect for the committee's time, I'll conclude my introduction and certainly stand for any questions that the committee may have.
Thank you. Any members have any questions about the request? Can you say, I guess, what page or where we can find what the, oh, here it is, on the last page 8, is that where the fee changes you've identified that you'd like to?
Madam Chair, I'm not sure if I have the handout that you're looking at.
Oh, okay. On the change pages.
Yes. Yes, the main, Madam Chair, members of the committee, the main fee changes we're looking for are an increase in the application and renewal fees for our DPM licensees. We're seeking an increase in the ceiling authority from $600 to $1,000. We don't expect to go there right away. The board has determined that setting that fee in the interim at $750 would be a good place to start. And with the benefit of a biennia under that fee structure, we'll see whether or not that closes the gap.
Okay, thank you. Senator Abler.
Well, thank you. I was planning to listen to this whole presentation and wait to get to the other stuff, but this idea about ceilings, it's a terrible idea. The Kairos have one, I don't know who else has one. These like blank checks to do whatever. I mean, our job is to scrutinize their work and make sure that they're lean and effective and protect the providers as they protect the public. I think that's, I don't remember ever hearing that before. I think that's one of the worst ideas I've ever heard. And so tell us what you need, be as narrow as you can get. This comes off the back of providers who are struggling with lousy insurance rates a lot of times, struggling to work with Medicaid rates. They don't have a lot of money, none of these people. So just I'll leave it at that, Madam Chair. Thank you.
Thank you. Any other comments or questions? Seeing none, thank you for the presentation. We'll take your thoughts into consideration and probably have some more discussion later on in session. So thank you.
Thank you, Madam Chair, members of the committee.
Next, we have the Board of Chiropractic Examiners.
Good morning.
Good morning, Dr. Ridge. Is it Pitty?
Pitty, that is correct.
Welcome to the committee, and please state your name for the record and begin.
Good morning, Chair Wicklund, Chair Key, and the members of the committee. My name is Dr. Ridge Pitty. I'm the Executive Director for the Minnesota Board of Chiropractic Examiners. The mission of the Minnesota Board of Chiropractic Examiners is to protect the public through effective licensure and enforcement of the statutes and rules governing the practice of chiropractic to ensure a standard of competent and ethical practice in the profession. The board has over 3,000 licensed chiropractors. Licensed chiropractors also have the opportunity to maintain registrations in 5 different areas. I'm here today to testify about change items to the board. This is the first time the board has asked for a fee increase since 1993. The board has 2 change item requests. Number 1, increase spending authority to continue to provide the services we provide. Additional funding of $100,000 in fiscal year 2026 and $100,000 in each subsequent year from the state government special revenue fund to help address operating costs increases at the board. This will allow us to address rising cost pressures and mitigate impacts to current levels of service and information to the public. Number 2, we need to raise fees to cover the increase in our spending authority. This change item request is raising fees collected by the board to cover statutorily mandated operating expenses. Again, fees have not been increased in 32 years. The board is entirely fee-supported and receives no general fund dollars to support its services. Rising rates in rent, salaries, technology, legal services, and other costs of doing business have resulted in a growing gap between revenues and expenditures. Finally, many of the board's fees are still written into Minnesota rules and need to be moved to statute. The approval of our 2 change items will enable the board to maintain core public safety responsibilities, including efficient licensing, managing complaints, and maintaining a balanced budget as required by state law. Thank you for the opportunity to present today.
Thank you. Are there any members with questions? Senator Liskey.
Thank you, Madam Chair. I'm having a bit of heartburn like my fellow senator over here. I'm reading through these. I do see in the chiropractic one the proposed not to exceed. The thing that I'm concerned with is that's basically like handing an open check for the next however many years, and it's going to be a lot of uncontrolled spending or uncontrolled raises that I, as a provider, have the same problem, right? I have a question of, okay, so not only am I getting shrunk on the reimbursements from insurance, and possibly if we go through with the proposed budget in the near future here, not getting any Medicaid payments over the course of the next, who knows how long that'll last. How is a provider going to be able to pay for the small increase, much or less the doubling that's in the proposed not to exceed? I consider that basically a blank check. How often are you going to raise them? When are you going to raise them? That doesn't answer these questions. And also, why are we giving a not to exceed number when we should have an idea of what the budget we need for the next fiscal biennium?
Yep.
Does that make sense?
Yes, thank you. Chair Wicklund and Senator Liskey, if you look at page, I believe it's page 9, but there's the proposed fee for the fiscal year 26. Those are our proposed fees.
Okay.
Senator Liskey.
Madam Chair, thank you. Yes, I see the proposed fees. My concern is that by putting the other part of the language in there with the proposed not to exceed, basically it's us saying, hey, we're your regulatory body, but we don't have to do our job, which here at the legislature, that's what we're supposed to do, is pay attention to these fees. We're not going to pay attention until you guys make it to that exceeded number. Does that make sense?
Yes.
And that's not okay.
Madam Chair, Senator Liskey,
Dr.
I
Pitti.
understand that concern. This language is standard in the other health licensing boards as well. Again, we have a duty to protect the public, and we have to balance our budgets, but of course, we can't spend uncontrollably either. There's a lot of checks and balances there to prevent that from happening.
Senator Liskey.
Thank you, Madam Chair. Yeah, and I understand that it's not just chiropractic. I'm reading through all the other ones, and I see that as well. It's something that I have a concern with all of the professions. It's not just chiropractic. It's just that I happen to be a chiropractor, so it's the one that I can understand the easiest. And so that's why it gets brought forward. And I think that's the same thing with Senator Abler. It's just that we both have that experience. And he said it the same way, as this not to exceed stuff means that we're not doing our job on our side. And so we need to focus on doing that as well. Thank you.
Any other members? Senator Aki.
Thank you, Madam Chair. And I got a question, but I'm going to first ask the beginning. Did you say it had been 32 years since it's last been adjusted?
Dr. Petey?
Madam Chair, Senator Aki, yes, that is correct.
Okay.
Chair Aki.
Madam Chair, I have a follow-up to that then. I just want to, that's what I wrote down and I want to make sure it was right. But have you come before this committee in the past asking for this? I mean, it just seems like a long time if we're adjusting our budgets as we go to all of a sudden come in and, you know, I agree with what I'm hearing across the table is the open checkbook part would be concerning and, you know, would hope that there would be a, you know, you'd be selling a budget. This is what we need. But I was just wondering, have you been turned down in the past? And that's why you're here today with such a gap?
Dr. Petey?
Thank you, Madam Chair and Chair Aki. I've been in this position for 2 years. This is my first opportunity to come before you.
Okay. Thank you.
Any other questions or comments? I think what I'm sensing is that, you know, members may not have been aware of this idea of proposed, you know, not to exceed sort of rate establishment. And what we can do is gather some more information kind of collectively about the boards and how they've done this work over the past, and maybe some historical information about how this process has worked. And then when we bring if we bring the items back, you know, for inclusion in a budget, we could have more discussion about that, whether that's a process that we want to just continue, because it sounds like there are boards that already have this in place, and we must have approved that at some point, and so we should look back at when those things happened, and then how we'd like to move forward, and if there's any other recommendations we could make as far as how to be comfortable with a ceiling rather than setting a specific fee. Because I do understand, I mean, these two entities so far have gone a long time without changing fees. And so I would expect that in the future, they're gonna have the same kind of care and consideration. But I do also understand that people are concerned about, you know, letting things be just in place without us having a chance to review. So, Senator Gruenhagen, did you?
Oh, thank you, Madam Chair. Yeah, I don't know, I'm just throwing this out for food for thought. What about getting rid of all these fees and then giving them money out of the provider tax? I mean, we're charging them fees, the provider tax, and I voted a number of years ago to get rid of the provider tax, and of course it's back. But, you know, these are providers, and why don't we just, if we've got these boards, they should take money out of the provider tax, which is already driving up costs, and get rid of all these fees. Anyway, just food for thought.
Thank you. Yeah. Thank you again, Dr. Pitty.
Thank you for your time.
Next, we have the Board of Dietetics and Nutrition Practice. Welcome to the committee, Ruth Grandel, and please state your name for the record and begin.
Thank you, Chair Wicklund and Chair Udke. My name is Ruth Grendel. I'm the Executive Director of the Board of Dietetics and Nutrition Practice. And if you'd indulge me to respond maybe on your not to exceed, would that be okay before I go into my presentation?
Sure, go ahead.
Okay. I'm not asking to have a not to exceed, but I'm going to tell you my experience with it was when I started with the Board of Dietetics and Nutrition Practice in 2013. Our renewal fee is $75. And we were charging $45 because we were absorbing our reserves, which we are only supposed to have so many reserves. So we were absorbing our reserves. And the OLA came in to audit us, and they were going to write me up. They said, how did you have the authority to lower your fees? So it can go both ways here, just so you know. And you're dealing with auditors. I almost said I can't lose either way. The legislature is going to see I lowered my fees, and my licensees lowered them. But we didn't have the authority, and we did that. So just so you know, it can go both ways on this, and I'm not asking to not to exceed myself here today. Thank you. The Board of Dietetics Nutrition Practice is responsible for the protection of the public through the regulation of dietitians and nutritionists in the state. The board was established in 1995 under the authority of Minnesota Statutes, Chapter 148. Dietitians and nutritionists are food and nutrition experts who work throughout our communities in hospitals, schools, public health clinics, nursing homes, fitness centers, food management, food industry, universities, research, and private practice. Currently, Minnesota has 2,500 licensed dietitians and nutritionists, and we have 107 applications in process. In comparison, in FY20, we had only 107 new licenses issued, and this year we're looking at 348. There's an absolute explosion, and I'm not sure exactly what's going on out there. It could be aftermath of COVID, that people think they can work virtually, but it's absolutely exploding for us. In FY21, so it was 176 in FY20, FY21, 191, FY22, 240, FY23, 276, and FY24, 328. And like I said, we're looking at 348 today. Our revenues, we're looking at projections this year of $300,000 if we're on target for the last 6 months of what we did last year. In FY20, our fees, what we collected, were $192,000, which is a 63% increase in 5 years. It was the same way, was steadily climbing. FY21 was $212,000, FY22 was $224,000, FY23 was $240,000, and FY24 was $284,000. We also do license verifications, which we've done 310 to date. We had probably 2,400 renewals just recently, and we had continuing education audits of 10% of those. So at the risk of stating the obvious, with the increased applications and revenues means an increased workload. I'm the only employee, full-time employee with the board currently. We have a vacant OAS position that I'm looking for the funding for the $60,000 in this budget to fill that position again. The increase will not result in fee increase. Obviously, you can see, well, our appropriation currently is only $217,000, and our revenues will be $300,000 if we hit our projections. So there will be no fee increase. And with that, Chair Wicklund and Chair Udke, if there's any questions, I stand for questions.
Thank you very much. Members, any questions? I guess not. Thank you very much for the information.
Thank you.
And our last board presentation, the Board of Pharmacy. We have Dr. Katrina Howard and Dr. Brock Reed. Welcome to the committee, and please state your name for the record and go ahead.
Thank you, Chair Wicklund, Chair Udke, and members of the committee. My name is Dr. Katrina Howard, and I am the Deputy Director at the Board of Pharmacy.
My name is Dr. Brock Reed, and I am the Controlled Substance Reporting Section Director at the Board of Pharmacy. One of the programs that I oversee is the Minnesota Prescription Monitoring Program, or PMP, and we are here today to present the Board of Pharmacy's budget requests.
The board is a small agency with 23 employees that serves more than 26,000 licensees and registrants. These include pharmacists, pharmacy technicians, interns, pharmacies, manufacturers, wholesalers, third-party logistics providers, and medical gas dispensers. Additionally, the board oversees several programs, including the state's prescription monitoring program and the opiate product registration fee program. The board is seeking 2 main requests. The first is to extend the availability of previously appropriated general fund dollars for ongoing legal costs through fiscal year 27. In fiscal year 24, the board received a one-time appropriation of $1.5 million, which is currently set to expire on June 30th, 2025. These funds were appropriated to cover legal expenses related to the lawsuit filed in 2020 concerning the Insulin Safety Net Program, Pharma versus Williams. Importantly, this request does not involve additional funding. Instead, it asks for permission to continue using the remaining funds from the original appropriation through fiscal year 27, as legal expenses are expected to continue into the next biennium. The board cannot absorb these ongoing legal costs without these funds. Currently, the board's appropriation is set to reduce in fiscal year 26. If a reduction were to occur, the board will not have the funds to maintain its current staffing and service level. Therefore, the second request is to increase the board's fiscal year 26 and fiscal year 27 spending authority by approximately $1.2 million to maintain its current its current operations. The increase in spending authority that the board is requesting is best broken down into three parts. The first is to maintain the board's existing operation, for which the requested annual spending authority increase is $905,000. There are numerous drivers necessitating this increase. First, the state's IT department, Minute, has quoted the board an annual increase of roughly $150,000 to maintain services for our small agency. This includes rate-based services, shared costs for 3 Minute full-time employees, and maintenance of the board's licensing system. The board cannot absorb $150,000 without increasing its spending authority. The board's rules, last significantly revised in 2011, are another driver necessitating the increase in appropriation. Given the complexity and size of the board's rules, the revisions needed, stakeholder feedback, and anticipated hearings at OAH, the board requests an increase in annual spending authority of $75,000. Thirdly, the board has historically operated with a lean appropriation, and last biennium, the board experienced tremendous transition. Notably, at the start of the biennium, the board was fortunate to migrate to a new licensing system enjoyed by 14 other health licensing boards. In doing so, the board was able to offer online renewals for the first time ever to pharmacies, manufacturers, drug wholesalers, third-party logistics providers, and medical gas dispensers. Furthermore, during this time, the board was not untouched by transitions in the workforce that many others have experienced post-pandemic. In the last 2 years, the board has hired a licensure supervisor, associate director of enforcement, executive assistant, legal analyst, 3 licensing specialists, and 1 senior licensing specialist. 5 of these positions were backfills, while 3 of them are created to help bring stability amidst significant demands and transitions in our small agency. However, during this time, the board has lacked sufficient spending authority to backfill a critical pharmacist surveyor position. For this part, the board requests an increase in spending authority of $227,000. Regarding the board's current appropriation, in fiscal year 25, the fixed expenses of rent, staff, and IT services are consuming 84% of the board's operational appropriation. Without the requested increase, the board's appropriation is currently set to decrease in fiscal year 26, and the fixed expenses of staff, rent, and IT will consume over 90% of the operational budget. This will leave insufficient funds for other critical operational needs. All of this said, it is imperative for the board to receive an increase in spending authority so it can maintain its current staffing and service level. The second part of the request is to enhance the board's operation by hiring an investigative senior position to improve the efficiency and resolution of complaint investigations. Presently, pharmacy surveyors handle both in-state pharmacy inspections and complaint investigations. Not all complaints require the expertise of a licensed pharmacist, and hiring a non-clinical investigator would allow the board to build out its enforcement unit and enhance investigative efficiency. This change would also enable pharmacy surveyors to focus more on facility inspections, which will increase the number of inspections completed annually. For this part, the board requests an increase in annual spending authority of $142,000.
The third part of this request focuses on maintaining the service level of the Minnesota Prescription Monitoring Program, or PMP, by increasing its annual spending authority by $150,000. Since its inception in 2010, the PMP has been a secure electronic database managed by the Board of Pharmacy, where pharmacies report their dispensations of controlled substances. It serves as a clinical tool for prescribers and pharmacists to consult when considering prescribing or dispensing controlled substances to patients. The PMP is a statewide program with over 37,000 active account holders, including physicians, physician assistants, nurse practitioners, pharmacists, and dentists. The board is requesting a $150,000 increase in annual spending authority to continue renewing the statewide integration license while maintaining current services. This proposal would allow the board to continue facilitating the integration of Minnesota PMP reports into clinical software through eliminating initiation and recurring fees for Minnesota healthcare facilities. Removing these financial barriers ensures greater access for healthcare providers to this time-saving feature and reducing disparities in access. Use of the PMP has increased year over year, with over 7 million unique searches conducted in 2024, 70% of which were through integrated access. We recognize this has been a lot of information and are happy to try and answer any questions you or committee members may have. Thank you again, Chair Wicklund, Chair Utke, and members of the committee for the opportunity to present today.
Thank you very much. Members, are there any questions for Senator Gruenhagen?
Thank you, Madam Chair. Yeah. By the way, I'm short a little money too. I don't know if I can get some appropriated. No, just kidding. Say, you know, on your legal actions, and again, I'm a lay person, just asking, you know, if memory serves me, we just appropriated an additional $2 million to the Attorney General. Are we coordinating with the Attorney General's office in terms of legal action versus, according to your testimony, it appears like we're almost duplicating more legal action as far as the Pharmacy Board. Why wouldn't the Pharmacy Board coordinate with the Attorney General if they wanted a particular action? If you'd like to respond.
Whichever, or whoever would like to respond.
Thank you. The Attorney General's office is the Board of Pharmacy's legal counsel.
Senator Gruenhagen.
Oh, thank you, Madam Chair. Yeah, then why do you need additional money if we just gave $2 million to the Attorney General's office? Memory serves me, last session. So why do you need more money for your own legal expenses, or how does that work?
Dr. Howard, it sounded like you don't need more appropriate, but you need to have it extended so that you can access it. Go ahead, Dr. Howard.
No, that's absolutely correct. We're not asking for more. We're asking to extend the duration in which it can be spent on legal expenses for ongoing litigation for which the Attorney General's office is our legal counsel.
Any other questions? Oh, Senator Mann.
Thank you, Madam Chair. I just wanted to highlight the importance of the PMP program. You know, it's a really critical tool that providers have to participate in fighting against the opioid crisis in this country. And it may sound silly, but the integration into the EHRs has been absolutely critical for its use. And so I just wanted to highlight for that for the committee, the importance of that program.
Thank you. Any other questions or comments? Seeing none, thank you very much for the presentation. And if we do have more questions, if members have them, I'm sure they can reach out to you and we can discuss some more later. So thank you.
Thank you.
Thank you very much.
And now I'd like to move to the Department of Health. Very glad to have you here with us today,
Thank you.
Commissioner, and Ms. Timian. And welcome back to our committee for this session. Please go ahead and introduce yourself and go ahead with your presentation. I'll let Lisa get the slides up.
Thank you, Chair Wicklund. Good morning. Chair Wicklund, Chair Etke, members of the committee. My name is Brooke Cunningham. I am the Commissioner of Health. I am so pleased to be here with you today, joined by my MDH colleagues to present the governor's budget for MDH. For those of you all who don't know me, I joined MDH in 2022 as its first Assistant Commissioner for Health Equity and became Commissioner in 2023. I am trained as a physician and as a sociologist. I do primary care, internal medicine, and in my time at MDH, I have been impressed by the sheer scope of our work. Although most people know public health for its infectious disease work, as Deputy Commissioner Underwood shared with you all last week, while infectious disease is core, we do so much more than just infectious disease. At MDH, we work with communities to protect drinking water. We identify new substances when they get introduced into substances of abuse. We make sure pregnant women and infants get nutrition and breastfeeding support through our WIC program. We make sure that infants are screened for treatable conditions at birth in our newborn screening program. We support clinics to work with communities to address chronic disease, and we support the 988 suicide line and community-based strategies to prevent substance use and misuse and recovery. And we regulate a number of entities, both through our Health Regulation Division and our Environmental Health Division. At MDH, our mission is to protect, maintain, and improve the health of all Minnesotans. Minnesota's quality of life depends on thriving, vibrant communities. Healthy communities set the foundation for long-term health and well-being, which means protecting people from infectious disease, from environmental threats. It means, as I've noted, clean water, strong schools, meaningful work, community connectedness, access to healthcare, and other important community supports. In public health, we work to change this context of health so that it's easier for all of us in Minnesota to be our healthiest, no matter who we are or where we live. We prevent illness before it starts. So while our health policy team examines barriers to access and our chronic disease unit supports community health workers, public health is not so much about going to the doctor. We certainly study payment, we regulate HMOs, DHS pays for health services and provides some direct care and treatment. We in public health focus on the upstream determinants of health. We want to prevent disease and injury. Public health professionals use their education and expertise to look beyond individual health to identify patterns in health across entire communities that affect many, many individuals, many, many Minnesotans. And so our solutions are at the population level. You all, as we move into talking about the budget, you all saw this slide last week. We do all of this with relatively small investment of the total health budget for the state. This slide, that green, that $400 million, shows the amount spent across the state by local public health departments relative to health care. So across the state, public and private sources spend $66.8 billion on health care and paying for health care and covering people, but local public health departments only spend about $400 million across the state, much of that passing through our department. And what isn't shown here is that because Minnesota's population has grown over the last 20 years, the number of local public health professionals per capita has actually decreased by about 22%. We've gone from 59 FTEs in local public health departments per 100,000 people to 46 per 100,000 people. These are the people who are working in your communities. These are the people that these monies that we get from federal and state sources help to support. And our recent cost and capacity assessment found highly variable the level of public health services across the state, in part because public health has been historically underfunded. As MDH, our role is to collaborate with local public health departments, tribal governments, and community-based organizations to keep each other informed of emerging health threats, to develop solutions together, and to collaborate to promote well-being and prevention. And we do that with the resources that you and your colleagues provide, and again, the resources from the feds. As may have been mentioned last week, approximately 50% of our department's funding comes from the federal government. And so while we operate on tight budgets, what would we be able to do if more of that health spend was spent on public health? What would happen if we could devote more resources to address policies, systems, and surroundings that shape the health of entire communities instead of paying for expensive individual medical care after the fact, after someone got sick? We'd see a great return on investment, which is what this figure shows. We'd have tremendous positive social societal impact. An ounce of prevention is worth a pound of cure. So as I move to our specific proposals, knowing that we are facing challenging economic headwinds, our approach to funding programs at MDH is responsible, measured, and honest about our needs. The general fund increases that we are asking for are due to 2 proposals recommended by the governor, one in infectious disease, really a core area of public health, and another operating adjustment, which also includes funds from the general fund and the healthcare access fund. We have some SGSR proposals and some clean water proposals that I'll review quickly as well. This slide is in your packet just to give you a basic overview of where the monies are coming from per fund over the next 4 years. So, infectious disease, prevention, early detection, and outbreak response. Infectious disease is core to public health. Early detection of and response to infectious disease protects Minnesotans, saves lives, saves money. Quick responses to outbreaks keeps kids in schools, keeps restaurants open, keeps people working, and keeps folk safe, and provides health care savings. Now, you all know, right? There are a number of ongoing and emergent infectious disease threats. Measles, avian flu, right, H5N1. Seasonal influenza, RSV, rabies, foodborne outbreaks, sexually transmitted diseases, right? And vector-borne disease transmitted by ticks, transmitted by mosquitoes, and of course, zoonotic diseases that I've already mentioned, H5N1. And we have vulnerable people in our communities, right? Among our friends, among our family, those with comorbidities. We have folk who have difficulty accessing care, folk who are unhoused, folk who are immunocompromised. And without stable state funding for infectious disease response in Minnesota, follow-up for certain diseases and outbreaks would be delayed, hindering our ability to mitigate a timely response. Timely public health response helps control infectious disease so less people get sick, so there are less hospitalizations, so there are less deaths. So this budget proposal of $2.6 million in the biennium ensures that MDH can continue performing key activities, our disease investigations, identifying outbreak sources, conducting the requisite laboratory testing, alerting the public and healthcare systems about health threats, and developing activity and guidelines to prevent the spread and curb outbreaks. The proposal also seeks funding because we need to compensate for the loss of federal funding for these activities. And certainly, we have had losses to our federally funded programs already. Now, operating adjustments, $3 million in the general fund, $4.27 million in the healthcare access fund. Clearly, operating increases are never fun to request, but the reality, as you have heard from the boards this morning, is that it is costing us more to do our work. This funding will help cover expected growth in employee compensation and insurance and other operating costs. Again, we just talked about the health spend budget, the state as an agency, the state as an entity, MDH as an agency have to cover those employer-related costs, escalating healthcare costs, healthcare contributions to Medicare, to Social Security, other salary and compensation-related costs, and other operating costs that my colleagues talked about in terms of rent, in terms of IT, minute costs, legal services. All of these are growing. And so with this, we are asking for some operating adjustment to reflect the rising costs of operations. There is a piece of our proposal that also would give us additional flexibility to address upcoming operating pressures, including the authority to transfer administrative funding between programs with the approval of the Minnesota Management and Budget and notification to the legislature, the ability to retain up to 10% of competitively awarded grants if administrative funding is not already appropriated, and the ability for executive branching agencies to carry forward unexpended non-grant operating appropriations. Without these resources, clearly the impact could be less staffing with an impact to service delivery. And as I've mentioned, for an effective public health response, it needs to be timely. We've got to respond, whether the public health issue is an infectious disease threat or something happening in a healthcare facility. We have been looking to maximize efficiencies. Clearly, we've consolidated and reduced our space in St. Paul and our district offices. We were capitalizing on the opportunity that hybrid work brings us, and we are ongoing reviewing our technology and our required cloud infrastructure usage through ongoing assessment of our tech applications and services. So we are doing our part at the agency, but we would appreciate the operating cost adjustment to address those rising costs that I described. We have a number of budget neutral proposals. These are technical, cost neutral. We want to continue the Early Hearing Detection and Intervention Advisory Committee and eliminate the committee sunset. The advisory committee was established in 2007 when hearing screening was added to the newborn screening panel. Currently, the advisory committee is set to end in 2025, and we would like to continue operating without a set expiration date. The proposal will continue this work without an end date, and we have the money to do this through revenue that we generate through Minnesota's newborn screening panel. Next, we would like to shift the Maternal Child Health Advisory Task Force to an advisory committee, which signals that this work should continue and aligns with the intent of our funding from the work. As you all know, a task force must expire. By definition, it only functions for a limited time, whereas an advisory council expiration date is prescribed by their section of law. So right now it says that the task force should not sunset, but that's inconsistent with the definition of a task force, so we like it to be an advisory committee. Going on to cannabis funding, we are asking to restore a shift in funding back to local and tribal public health departments for cannabis and substance misuse prevention grants to ensure that local health departments have the resources needed to address cannabis and substance misuse in their communities. We are doing this by reducing an appropriation for the substance use treatment, recovery, and prevention grants. This allows this to be a budget neutral proposal because we are essentially shifting funding from one pot of money to another. Repurposing these funds allows MDH to provide stronger support to locally led prevention efforts while retaining significant funding, $3 million, for discretionary grants for substance use treatment, recovery, and prevention. Clearly, the public health system is a system that really relies on local public health departments and tribal partners to partner to really address the needs of their unique communities and deliver programming that is responsive to those needs. So this would allow us to, again, support our local partners and leverage those partners to address the substance misuse epidemic. Again, it's budget neutral. And we have talked with partners about this shift, and we believe we have left significant money, that $3 million in the substance use treatment, recovery, and prevention bucket to complete that work. The American Indian Special Emphasis Grants, again, thank you all for funding in our base budget, the Office of American Indian Health in 2023. As we funded that in 2023, we had the grants listed as competitive grants. We want to remove the competitive requirement for tribal nations, so that removes the burden for tribes to write grant proposals that are competitive in response to a request for proposal. We would do this with 75% of the monies, leaving 25% to continue to be competitive grants to urban American Indian organizations. We'll move to our State Trauma Advisory Council. Minnesota's trauma system is a coordinated network of over 120 hospitals, approximately 300 ambulance services, working collaboratively to optimize the care provided to seriously injured people. This system ensures that seriously injured people are promptly transported and cared for at hospitals with resources to match their needs. This is an important advisory council that should continue to advise, consult with, and make recommendations to MDH on the development, maintenance, and improvement of our statewide trauma system for at least 10 more years, and that is the request in this proposal. PFAS biomonitoring with firefighters. We are currently working on a project to create a procedure, so recommendations, protocols for conducting PFAS biomonitoring in firefighters who are at a much higher risk for PFAS entering their bodies due to the materials that they work with to fight fires. This is an ongoing project as MDH is working with experts to develop ways to detect these chemicals in the body, which is known as biomonitoring. This project was fully funded. We just need a bit more time to complete this important work. Now we are going to move into our fee proposals. There are two linked but distinct proposals to address the needs of our health facility licensing work. We are asking for an increase in our assisted living fees. This investment is an increase to appropriations through a fee to account for the higher volume and complexity of the workload and the regulation of health and safety investments in assisted living facilities. Clearly, as the state's population ages, there's greater demand for assisted living, and our capacity to license and regulate those facilities has not kept up with the number of entities that want to come in and provide those services. So these fees will help us keep up, give us the resources we need to meet the increased demand. This increase will enhance staffing in the areas of licensing, surveys, enforcement, and reconsiderations to ensure proper care and services. Again, since we went into licensure in 2019, there are 25% more providers, assisted living providers, than were initially anticipated, and that is only expected to grow. And we have not raised fees since 2019. Now, we license a number of other facilities which have different fee increases from 2001 to 2015. And so to keep up with all of our work across all of the types of licensees, we would like increased fees for licensing and certification. So let me just list off to you the last time these facility types had license increases. Boarding care homes, 2001. Hospice, 2002. Hospitals, 2009. Outpatient speech services, 2009. Birth centers, 2010. Supplemental nursing service agencies, 2015. So again, costs have gone up over that time period. In terms of engineering plan review fees, we are asking to increase fees because under current law, MDH is required to review engineering plans for new construction and modifications in healthcare facilities. This investment will increase engineering construction plan review fees to align with current costs to review these plans. The complexity and number of plan review complaints are increasing with the expansion and modernization of nursing homes, hospitals, and other healthcare entities. And by providing the engineering team with the adequate resources needed, the department can better oversee regulated facilities to ensure they meet the appropriate safety standards which benefit Minnesotans and their loved ones who receive care from these entities. Fees have not been increased. These engineering fees have not been increased since 2013, while the plans and the modernization has become more complex. We have an HMO fee increase. This is, of course, different than DHS's proposal in this space. Our fee is around the initial application fee and the annual renewal fees to cover regulating HMOs. Clearly, HMO regulation has become more complex. There's been new federal regulation and new requirements. The legislature adds health coverage mandates nearly every session, and the corporate structures of healthcare entities continue to become more complex. So these fees will cover growing personnel and other operating costs, which have not been adjusted for inflation. The last time HMO fees for application or renewal were set were in 1999. Food pools and lodging fees. The number of establishment license issued, as well as the number of required inspections, has increased significantly since our last fee modification, which was in 2017. In fiscal year 2017, there were 14,500 license issues. In fiscal year 2024, there were 16,443 license issued and 16,736 inspections. So we are asking to increase that fee to maintain existing support of education, licensing, construction plan review, and inspections at food, beverage, lodging, public swimming pools, manufactured home parks, recreation camping areas, and youth camps across Minnesota. This will also align the collection schedule of the statewide hospitality fee from establishments licensed by the 26 delegated agency programs. Radioactive materials fees have not, again, the story is basically the same as I go through all of these proposals, right? Fees have not kept up with current operating expenses for required agreements with radioactive materials. The latest fee change for this one was 2021. We want to be able to provide timely customer service to radiological licensees, and this would help us do that. Clearly, inspection frequency delays are expected to increase if we do not get this fee increase. We also have X-ray radiation inspection fees. Again, we want to increase funding to support the program operations, compliance, and education to reduce unnecessary ionizing radiation exposure. This introduces regulation for service providers repairing and testing X-ray equipment, shifts inspections from a fixed 4-year cycle to a risk-based approach considering radiation dangers, and reauthorized rulemaking for certain X-ray uses approved last in 2017 and 2019. And the latest fee adjustment was 2009. Asbestos. Asbestos is still found in over 3,000 building materials. The risk of inadvertent asbestos removal is high and dangerous because no preventative methods are used to contain the potential release of asbestos fibers when the asbestos-containing material is removed or disturbed. So this latest fee adjustment was in 2021, and this will increase appropriation to increase capacity in our asbestos abatement regulatory program and increases project permit fees for asbestos work. Current staffing levels supported through fees allows the program to inspect 10% of asbestos abatement projects, and EPA expectations are that 30% of projects are inspected. Clearly, without additional staffing resources, this inspection deficiency would worsen and lead to potential public health threats. Public water supply fees. This investment is for ongoing state government special revenue fund fee and appropriation increases to support expansions in the Safe Drinking Water Act requirements as mandated by the U.S. EPA. Although there are new requirements, our drinking water protection project is projecting a reduction of $60 to $70 million in EPA funding over the next 3 years. We need additional support to maintain operations and staffings to meet the new sampling requirements, the new responsibility to administer the new federal rules, and to modernize our drinking water protections information technology systems. These fees will help us maintain our current work and capacity needed to provide regulatory oversight and technical assistance to the 7,000 public water systems that we help support. And our well management fees, this investment is for ongoing state government special revenue fee and appropriation increase to ensure the construction, maintenance, and sealing of wells and borings to make sure that they are conducted in a manner that protects public health, groundwater, and the environment. There are no new FTEs, but this will maintain our current ability to do this work. This proposes fee increases for licenses, notifications, permits, and variances. Operating expenses for staff, minute, costs, equipment, and supplies have increased beyond the existing appropriation. And clearly, again, we want to show up and meet our responsibilities and public expectations, and delayed technical support and oversight to well management customers we'd like to avoid. And certainly there are emerging issues as well in the well space. And then we have a number of clean water proposals that you all can review in the packet. Thank you all for your attention during that presentation.
Thank you. Thank you very much for the presentation. Members, do you have any questions? Senator Liskey.
Thank you, Madam Chair. Madam Chair, Commissioner, thanks for the presentation. I have quite a few questions, but we're going to start with hopefully an easy one. I heard you talking about on slide 7, specifically federal funding and how things have changed. What federal funding has already been lost when you were talking about federal funding being lost already? Can you tell me what federal funding you're talking about?
Yeah, we have some core
Commissioner
grant that
Cunningham?
supports our, sorry.
Go ahead.
Chair Wickland, thank you. Senator Liskey. We have some core funding that supports core programs that we get continuously from the federal government. Of course, there are COVID monies that are dropping off of July 2026. That's about $3 million. That's anticipated, but we have also seen these core larger grants get reduced. And so there are areas of funding reductions in healthcare-associated infections. When we went in for our grant, for example, to meet the need, we asked for close to $2.5 million. What we got was $423,000. So we are seeing that magnitude of cuts in traditional programs that has supported infectious disease, not only in healthcare-associated infections, but in foodborne illness and tick-borne diseases and emergent infectious disease. So we are seeing a number of areas get cut in sexually transmitted diseases of significant magnitude that affect our state's ability to respond.
Senator Liskey.
Thank you, Madam Chair. Madam Chair, Commissioner, again, I guess my question is, do we know why they're being cut? I would imagine this isn't just because of the changing of administration. This probably was already decided prior to the current administration. Do we know where the causes of cuts like that are happening?
Commissioner Cunningham.
Chair Wickland, thank you, Senator Liskey. At the federal level, they balance budgets in the same way that you all do, and I think what is happening is the constraints at the federal level that CDC has to sort. They make choices and prioritization. It's not that the threats are not going down, but I think it is always, both at the federal level and I would say also at the state level, public health just has not been fully invested in.
Senator Liskey.
Thank you, Madam Chair. That actually teed me up for my next discussion is preventative health care and preventative options. I agree with you, your presentation talking about how important it is to prevent illness or to prevent a more serious illness. Looking through the governor's budget, as I expressed about last week, it's very disappointing that we're cutting preventative health care when we're talking about preventative health care being the best way to curb costs. The other question I have is related to the entire presentation, because I heard you say the word fees, I think at least about 150 times. Not sure, might be exaggerating, might be not. My concern is that we talk about reducing the cost of health care, but it doesn't sound like the government is willing to reduce their costs that coexist with that cost of health care. In fact, it sounds like we're going to be raising our fees, or at least that's the proposed budget. And by raising those fees, we raise the cost of healthcare. I don't really care how we want to talk about it, because at the end of the day, every fee on a provider or an insurance agency or anything like that gets passed on to the consumer. The consumer is the patient is the one receiving the healthcare. So we talk about this problem of increased healthcare costs, but we ourselves are not limiting ourselves on the cost. And so I have concerns hearing all these proposed increases in fees. It's not going to reduce the cost of healthcare. So, thank you.
Senator Liskey, I don't hear necessarily a question, but I don't. Commissioner Cunningham, did you have a response?
Thank you, Chair Wickland. No, thank you.
Okay. Senator Port.
Thank you, Madam Chair. Thank you, Commissioner, for your presentation. I want to, commend the work that you're doing at Public Health with a very small budget in comparison to the rest of the expense of healthcare in our state. And as you're talking about, approximately 50% of your budget comes from federal funds, are you expecting today that that will be impacted by the pause on all federal grants at the national level?
Commissioner Cunningham.
Chair Wicklund, thank you. Senator, clearly, with that announcement coming out yesterday, we're sort of waiting and seeing, and we'll wait and see what comes down from the feds. I am someone who wants to protect funding for public health. I think that is critical. I think public health is, a bipartisan team sport, and I think it is important for us to maintain that funding. So we will see what comes out of DC and out of the feds, and certainly if it impacts MDH, part of the point of my presentation is it impacts all Minnesotans, right? Because our federal funds, we pass through to local public health departments, to community-based organizations to coordinate a public health response.
Senator Port.
Thank you, Madam Chair. Thank you, Commissioner. When you were specifically talking about like the avian flu and the food boards, things like that, can you sort of paint a picture of what that looks like in Minnesota, how we are implementing those sorts of hopefully protections, or at least early warning signs for Minnesotans?
So
Commissioner Cunningham.
Chair Wicklund, thank you, Madam Chair. Thank you, Senator Port. So again, part of public health response is funding. Part of it is information sharing and coordination, and part of it is data. And part of it is providing treatment to those, making sure people not only have information, but have the ability to get tested and treated. With the coordination means coordinating both with our state partners, like the Board of Animal Health, a One Health approach, thinking about zoonotic, H5N1 is a zoonotic disease transferred from animals can be transferred from animals to humans. Our epidemiology teams maintain surveillance and work closely with farmers and our Department of Ag to maintain that surveillance. And then we clearly have to maintain trusted relationships so people feel safe to be tested should they have symptoms. And so we have shown up. We have done several testing of a number of farm workers, continue to provide information, to continue to establish those trusted relationships with those partners. And it is important that in the information sharing, that we know what's happening across the country, right? Part of the H5N1 issue is migratory waterfowl, right? And so migrating from community to community. And so that is why it is good for us to be in communication with partners across the country, which our teams do.
Senator Port.
Thank you, Madam Chair. Thank you, Commissioner. I really appreciate that. And as you learn more about how our federal partners that will impact this work in Minnesota, would really appreciate if you'd keep the committee updated.
Thank you. Senator Abler.
Thank you, Madam Chair, and I'm aware of time, so I have a comment and just only one question. So, Commissioner, I'm glad you're here. I've enjoyed getting to know you. And I appreciate what the department does in their efforts. There's a however coming. But I think we all need to be aware of the times. In 4 short years, there'll be no way to pay for your budget, or education budget, or the human service budget, or whatever, by a considerable amount. I understand we chatted about what you need to do in infectious disease and all that. I'm for all that. I had to sit through in 2011 a very challenging time where all the planets lined up. The Great Recession had affected us, and so we had to make some extremely hard choices. In a similar time in 2003, we were a little short by a sniffle compared to the bad things that was in 2011, and luckily for us, the deficit of 2011 is still a couple of years out, but we all know it's there, and the indicators are clear. And so in 2003, I coined the phrase essential, important, and nice. And people went through a process of deciding what was really the most important. And so generally, I see our budget as being untenable. There's about $139 million of new spending by my math in it. I'm willing to be corrected. And yet at the same time that your department is overseeing nursing homes and between DHS and all the rest, assisted livings, home care operations, which are getting actually reduced funding that I believe is even untenable, while at the same time, everything's going to sail on just as normal with expanded services at your department. I just don't see that as realistic. And we've talked about this a bit, but I'm going to bring it up again next time we chat. And so every fee you have on here is on some little thing, a person, a company, or whatever. There's a, where did I put my sheet here? So it's, sorry, there's $87 million worth of fees in there, which is not an incidental number. And I appreciate the fact that you're struggling for money. I do not know why any agency or school district or anybody took COVID money and built permanent programs on it. My school district as well, I'll criticize them. What were you thinking? We knew it was one-time money. And so, put it into technology or whatever. But in the economic reality situation we have and the political reality situation we have, I will take your bill, your budget, as what you wish could be. And I've asked people come to me, what should I put in a bill for? Put in a bill for what you'd like. Put in a bill for what you think would really help your particular home care thing, and ask for $100 million. And I take your budget with the fullest respect of what you wish could be. But I urge you, as we go forward in this very unprecedented time, to go back into the workshop and come up with some way that you can live with minimal fee increases, consolidate programs. In 2011, Madam Chair, I learned that if you have a refrigerator and you're going to clean out your fridge, and you have a pickle jar that's half full and a pickle jar here that's half full, and you put them together, do you know what that's called, Madam Chair? A cut. And so it's a time to consolidate, focus on outcomes, and not on just how much money goes into a program as the judge of success of it, but what are we getting for it? Is public health better? Is the health of the various disparities better? How do we focus on that? And to build a collaborative approach. Like it or not, the House is going to be tied someday. We're within a vote here. And so this is going to be really, really hard. Harder than anybody expects about what's going to happen come probably June 20th. And there's no special master to support the things we care so much about. So we're going to have to find a way to get this together. So Madam Chair, I just have one more question. My question is this, how do you defend using the Healthcare Access Fund for operations?
Commissioner Cunningham.
And you can comment on the rest if you want, or just take it as my thoughts, Steve.
Chair Wicklund, members of the committee, Senator Abler. Senator, let me start with the point that you were making. We are in tighter fiscal times. This is to maintain the work that we are doing. There's not an expansion in any of these proposals. All of these proposals are really to maintain the work that we do to protect the health and safety of Minnesotans. And so the cuts that we anticipate happening, that we have already seen happening, will significantly affect the work that we do. When we think about infectious disease, our infectious disease work is 90+%, maybe 100% covered by the feds. right? And so, and that is an area where I do think the proof is in the pudding, where there's been a great demonstration of improved outcomes. It is where public health started in infectious disease, right, in terms of sanitation, right? So I would say part of our approach, and I share this when I talk to other leaders in the healthcare space, is if we could get ahead of the curve with prevention, with the preventative efforts that are part of public health, we would decrease those downstream costs. We would bend that curve of spending at the state level for healthcare. And so I guess I would implore us to continue to invest in public health, because over the long term, right, over the short term and the long term, particularly short term with infectious disease, but over the long term, we are the solution to bending the healthcare cost curve, right? We are not contributing to the healthcare cost curve as much as reducing its growth with our efforts. With the Healthcare Access Fund, I could turn to my colleague, Legislative Director Timian, or our Budget Director to speak to the Healthcare Access Fund for me, please.
I'm sorry. Lisa. Yeah.
Madam Chair, members of the committee, Lisa Timian, Director of Government Relations for MDH. Senator, I was actually just looking in our materials. I don't know exactly what piece of our operating budget is coming from the Healthcare Access Fund. Would you allow me to just dig into that a little bit more, and we can get back to you about
Sure.
what that breakdown is? Because I just don't have that handy in our change page.
Yeah, the
Senator
total is
Abler.
about $10 million.
No, right, I see that. I just don't know. I don't know how.
Ms.
Sorry, sorry, Chair Wicklund. First time up here. Senator, we'll get back to you with like that breakdown and explain to you what piece of the Healthcare Access Fund is from operating.
Madam Chair.
Senator
I
Abler.
appreciate that, and I know this is, and I'm trying to be as polite as I can be, and you know I care about public health.
Yeah.
You know I care about every one of these projects you have, but I'm just telling you, in these hard times. And so if you take every lever of every money you could possibly get and use it up now, I don't know what the feds are going to do. We're short $36 trillion. I worried about it. I sat in that chair, a different one, Madam Chair, and I said, we're $10 trillion in debt. We'd better be careful. I was wrong. It didn't matter. But it's real money, and it's everything we can do is chase federal money. And so we need to be aware of whatever reality is going on about that massive debt, and prepare our own way. And I'm just telling you, if you use every fee, every fund now, we're not going to have any capacity to adjust to whatever. So thank you, Madam Chair. I'll relent. So thank you.
Okay, thank you. In the interest of time, I'm going to move on to, we have two other people who want to ask questions, and then we do have another presentation. So Senator Bolden.
Thank you, Madam Chair. I will be brief. Thank you for this presentation and for all the work that your agency is doing. I'll just echo my request, as Senator Port mentioned, as you learn more information about what the impact of the actions at the federal level related to the pause in grant funding, what that means, as hearing that 50% of your budget comes from federal dollars, that raises flags for me of the potential real impacts for Minnesotans. And my question is related to this slide 7 around infectious disease prevention, and appreciate all the work that you all do around emerging outbreaks. And you mentioned measles and H5N1, and just this morning I heard about a TB outbreak in I believe another Midwest state. And so these things are certainly happening. I'm wondering, as we are hearing from the federal administration, the pause in research and communication, you mentioned, part of your work is related to funding, but also part of it is related to information. As it seems like that information is not going to be available, certainly in the same way it was before, can you just talk briefly about the impacts of what that might mean for Minnesotans?
Commissioner Cunningham.
Chair Wicklund. Senator Bolden, thank you for that question. Clearly, information is key. Information is the key to understand what is happening in other jurisdictions, whether they are domestic or global. We can learn from others. We can learn how they respond, how they develop tests, the strategies that they use, and we can look out for symptoms when people are infectious as they come into communities. People move, animals move. I think it's just critical to have information, and my hope is that this is a pause that ends on February 1st in terms of the information pause that we've seen from the feds, because we need to be able to talk to each other, and we do rely. I was saying to my team, the information that comes out, particularly about infectious disease, are must-reads, right? There are ongoing meetings of federal partners with state partners to share information so that we are all abreast about what is happening and the strategies that other places are implementing, which gives us a heads up should we have an issue here at home in Minnesota. So I am concerned about the pause, and I am hoping that it is lifted on February 1st, and certainly the same concerns about the grants, and we'll be happy to follow up with you as news comes down.
Thank you, Senator Bonin. Senator Gruenhagen.
Well, thank you, Madam Chair. I've got a number of questions, but I'll just ask one. One thing to keep in mind, when you grow government at the rate that we did last couple of sessions at 40% plus raise taxes more, it's an expense on the private sector. It affects all areas. It drives up cost, and the private sector can't grow at that rate. So in effect, you do more damage than good, okay? Because of the weight of government on the private sector and the driving up of cost for the average citizen makes more problems than it solves. And it's just something to keep in mind. So my question's on slide number 4. I mean, it says that for every dollar invested in public health, then we're saving $365 million on obesity-related spending, and it goes on to say we're reducing death from all causes. What objective standard do you use to come up with these figures? I mean, is it the amount of pounds lost by people, or, it's related to obesity? And how do you measure that? To me, I don't have a lot of faith in that figure. So, but anyway, if you'd like to respond.
Commissioner Cunningham, if you can give us where that particular statistic came from, or if you can't describe, right now, if you could send it to us where that particular one, spending $35 million, $365 million was saved. Commissioner Cunningham.
Chair Wicklund, Senator, thank you for the question. We are happy to provide you with those citations that we list there so that you can dig deeper into how those figures were calculated. We don't have them handy here today, but happy to provide.
Senator Gruenhagen.
Just one follow-up question or comment, Madam Chair. What I'm interested in, is it objective standard or is it subjective? To me, it's pretty subjective. I'm a layperson, could be wrong. I would like to know what the objective standard is. How do we come up with reducing obesity, $365 million? I mean, do we measure it by pounds lost, or how does that work? Anyway, that's all, Madam Chair.
And I believe, Commissioner Cunningham, that you will be able to provide.
Yes.
And it will be able to state, that it is objective data collection that they're basing this spending reduction on. Okay, we have one more question, Senator Mann.
Thank you, Madam Chair. We know that healthcare spending is the highest in the U.S. as compared to any other high-income country, but we have the lowest life expectancy at birth. We have the highest maternal mortality rates. We have the highest infant mortality rates, and we have the highest death rate for treatable diseases. So that's something for us to also keep in mind. The common clause, of course, is that we are the only country that does not offer universal health care. We're the only country that says you are only worth health care if you can pay for it. We're the only country that does that, and we have the outcomes to show for it, something to keep in mind. The beauty of what I do, the beauty of working 7 days a week, 6 days, 7 days a week during session, is that I get to leave here and see exactly what the words that we say in this room have impact in real life. Last weekend, I had a patient waiting for a hospital bed for 42 hours. He was in the ER for 42 hours waiting for a hospital bed. This would not have happened had people been vaccinated for COVID, vaccinated for influenza, if people had stayed home with their newborn infants instead of letting them go to daycare to get RSV, these things would not be happening if it weren't for prevention, right? So I thank you very, very much for bringing that to the forefront, public health and prevention. We spend less on that than, of course, any other country. And we, of course, are paying for it because it is more expensive to treat something than it is to prevent something. So I want to highlight that. I want to thank you for that. And now more than ever, I want this committee to be on the same page. None of us can sit here and say what we're doing is working. None of us, because it's not working. And as of 5 p.m. tonight, when our federal funding is put on pause, that 42 hours is going to go to 50, 60 hours because all the funding that he's using to prevent these people from ending up in the ER is going to be gone. Also something to keep in mind. So thank you.
Thank you, and I don't hear a question in that. And at this point, just in the interest of time, I really want to thank you for coming and presenting to us today. I think it is a testament to the importance of public health that we want to spend time on these discussions. And again, thank you very much for your time. If members have more questions, I'm sure they will reach out. Thank you.
Thank you, Madam Chair. Thank you, committee members.
And next, we will move to Commissioner Harpsted and the Department of Human Services and her team. And in the, to, acknowledge that we are running behind schedule, I hope that you can go through your presentation and help highlight for us. I've noticed you're highlighting proposals, you're not going through every proposal. And then that members, please take notes on areas where you would like more information. And then I hope that the department, if you can please take note of members where they have more questions, that we aren't able to, fulfill all the discussion time today that's needed. And work to schedule meetings with members to discuss, if there are proposals that people have questions about. And hopefully we can get through the presentation and leave a few minutes for questions. So thank you again for coming today, and thank you for your service to the state. I really appreciate all of the work and the time and contributions that you've made over the past few years, and appreciate that we're able to have this presentation today before you move on to your new roles. So thank you, and please go ahead with your presentation.
Thank you very much, chairs and the members. Jody Harpsted, the Commissioner of the Department of Human Services. I'd like to present our budget proposal here. Our mission is in collaboration with community and partners. The Minnesota Department of Human Services supports people to thrive in community and live their healthiest and fullest lives. New mission statement this year. You can see how many millions of people we support in Minnesota, about 1.5 million overall of the people in our state. The governor's budget includes strengthening program integrity of human services programs, ensuring access, curbing increased growth in spending in some spaces, and increasing our operational effectiveness. This is what our budget looks like in terms of spending and the various accounts, and Elise will get into that detail later. I'd like to start with program integrity and compliance. Some of you saw my testimony last week on this, but to summarize, our Office of Inspector General detects fraud, waste, abuse, and error, takes action when they find it. We have a variety of tools, cases resulting from tips and referrals. We investigate, issue warnings, stipulate provider agreements, monetary recoveries, et cetera. We work with partners at the Bureau of Criminal Affairs, the Medicaid Fraud Control Unit, the Attorney General's Office, and the federal OIG. Recently, we can say that we have, over the past 5.5 years, conducted 4,000 investigations for fraud, stopped payment to 750 entities, 0.5% of the entities we oversee. We found no fraud in DHS from Feeding Our Future, but still stopped payments and disqualified individuals, except for a handful of folks that we were already tracking. Recently, we've done site visits to 164 autism providers and found primarily compliance issues, but still referred 24 of them to fraud investigations to be sure. In the last 10 years, growth in our Medicaid spending has outpaced the growth in our staff, including program integrity and compliance. This budget provides additional tools and statute changes to strengthen our abilities. So the first is detecting, preventing and addressing fraud, waste, and abuse in human services. And the first set of proposals is about more staffing, increased staffing in our program integrity, oversight operations, in our provider eligibility and compliance unit, and increased staffing for internal controls and audit investigations. The second category here is increased authority. And so we're looking for the ability to authorize the sharing of investigative data across state agencies, expanding authority to immediately suspend a license if a controlling individual is criminally charged with an offense somewhere else, allowing for a payment withhold when there's a criminal conviction related to fraud in another state or federal agency, allowing for payment holds when licenses are revoked or suspended, when someone has a background study disqualification, clarifying the statute of limitations when pursuing monetary recoveries, clarifying the substance use disorder midpoint rule, expanding oversight of MCO compliance, and funding for the ability to contract with a medical review agent. The next set of things is about data. We are excited about the possibility, especially of using AI and other advanced analytics in partnership with Minute to find new ways for these massive data tools to help us sort through the massive data that we have, especially in the Medicaid program, looking for patterns, finding things that seem concerning, and that sort of thing would help us tremendously. In addition to adding more people on the street going out to visits, we would love to pour through data and help direct those visits in the best possible ways. And then a couple things on background studies. First of all, a new background study disqualification would prohibit an individual under active investigation for fraud from holding any position of control or leadership in a program for which the background study is conducted, enabling us to disqualify people under active investigation for fraud from working in programs serving children and vulnerable adults. Next slide. Aligning our family, child, foster care, and adoption background studies with the federal Adam Walsh criminal history record check authority, and our federal child care final rule alignment, notification to a child care provider and prospective child care staff when the prospective child care staff can work under supervision and when they may not be allowed to. That's our set of proposals. We had more time to talk about it last week, but that's the whole package that we have as part of the governor's anti-fraud package.
Mr. Connolly?
Thank you, Chair. John Connolly, Assistant Commissioner for Healthcare and State Medicaid Director at the Department of Human Services. We do have a few healthcare-related budget proposals from the Governor and Lieutenant Governor to share. The first is extending access to audio-only telehealth. This really originated from a reform in the telehealth package during the public health emergency. During the 2021 session, there was an authorization of a package of telehealth reforms that allowed for audio-only telehealth. There was direction from the legislature to conduct a study, which was completed in September of 2024, recommending that this be continued. And so the proposal here from the governor and lieutenant governor is to do that through June 30th, 2027. And the main impetus behind this is to provide greater access to health services in Minnesota healthcare programs, particularly for those in greater Minnesota and those without technology to access audio and visual telehealth. Next proposal. This is really a technical update to our federally qualified health center rate methodology. So for FQHCs, as they're known, this really just clarifies in statute that when two FQHCs merge or one is acquired by another, that the rate paid, the encounter rate for the FQHC is really accounting for all of the costs of the two entities that are merging or are becoming one. And so this is just a formalization of how we pay the new entity that's been merged. Now moving on to a few of our savings proposals from the governor and lieutenant governor.
The first here is to eliminate the sunset of the Drug Formulary Committee. This is an important committee of healthcare practitioners, professionals that advise our preferred drug list, or PDL as it's known. And the PDL is a way for us to decide which drugs are receive prior authorization and are preferred, again, on our list of drugs covered in Minnesota healthcare programs. It's an important forum for us to provide, or to receive rather, feedback from healthcare professionals in addition to the public about decisions made around the PDL. And an important piece of this related to the budget is that the PDL and the maintenance of it every single year is important to us obtaining supplemental rebate revenue for prescription drugs in Minnesota healthcare programs. So that's really the budgetary import of this, in addition to kind of the public transparency piece and the professional input. The next proposal is related to the pharmacy carve-out. Currently, the pharmacy benefit within Minnesota healthcare programs is administered by managed care plans, or MCOs, within the medical assistance and Minnesota care programs. This is a specific carve-out within medical assistance. And again, here the motivation is related to the structural imbalance in the budget. We would seek savings of roughly 30% on drugs that are currently receiving rebates or discounts through the 340B program. Instead, that is a cost to the state in that we cannot claim Medicaid prescription drug rebate revenue on those drugs through our Minnesota healthcare programs. So this would seek to carve these drugs out of managed care, and then we would receive the prescription drug rebate revenue for those drugs through our fee-for-service program. I should note we would also seek or see savings of roughly $2 per member per month with respect to the administrative cost of MCOs administering the prescription drug benefit. We would have to spend some additional money on the state side in our fee-for-service program to absorb that volume, process those claims, and take care of the prior authorizations for those drugs. One more here is the increase to the HMO surcharge. Currently, that sits at 0.6% of total premium revenue for HMOs. The proposal here from the governor and lieutenant governor is to increase that to 1.25% of total premium revenue. And again, this is it's an increase of the cost of our programs and to address. And then I believe this is the final one related to healthcare, which is a benefit reduction being proposed to eliminate chiropractic care. The important thing here to note is that this is exclusive to beneficiaries or members of Minnesota healthcare programs age 21 and older. The early and periodic screening, diagnostic, and treatment benefit for youth and children in Medicaid does maintain the requirement that medically necessary services be maintained for children. So should there be medical necessity for chiropractic care for children and youth, that would still be available to those up to age 20 in Minnesota healthcare programs. And I'll pass it over to Elise.
Ms. Bailey, please state your name for the record and begin.
Hi, Chair Wicklund and members of the committee. Elise Bailey, Budget Director at the Department of Human Services, and I'll just breeze through some of our remaining proposals. This proposal provides a one-time investment to our HIV programs to cover a funding shortfall we have on the federal side. Starting next fiscal year, we'll have about $9 million less to spend on critical services to people who experience HIV, and this investment would allow us to mitigate that steep cliff next year. These services are really critical. In '23, we served around 10,000 people on the program, and from '22 to '23, we saw a lot of increased outbreaks in HIV, where new HIV diagnoses increased by 24%. So while we have our funding being reduced, the need is increasing. So this is a critical investment that you all could help us with to cover the gap in the first year of the biennium. The next proposal is strengthening our housing stabilization services. So this is a service under our medical assistance benefit that rolled out in 2020. And we were the first in the nation to have this kind of benefit on the medical assistance program, where we assist older adults and people with disabilities to help them maintain and keep housing. Since implementing the benefit, however, the demand for the services is much higher than what we had originally anticipated. And our department does the eligibility for both on the provider side and on the person side. And so right now we're at about a 3-month delay in processing applications, which is not ideal when we're talking about housing. So we're seeking an investment to fund 3 additional FTEs so that we can reduce that backlog and process applications more quickly, but also provide more robust training and technical assistance to providers so we ensure they know the rules of the program. We have enhanced program integrity in this aspect as well. On page 21 of our budget book is our operating adjustment. So this proposal is really to increase our appropriation to fund a portion of the increased costs that we'll have over time. And some of those increases include increased spending or costs in our healthcare contributions, our FICA and Medicare taxes, along with salary and compensation related taxes, as well as things like IT contracts, fuel and utilities that have grown from time to time. On page 35, our proposal on sustainable funding for accessing federal data sources. So this is a program called the Commercial Source of Income Program that we use to verify eligibility, income eligibility for our Minnesota Healthcare Program enrollees. This is a current system that we currently use. It has always been provided to states from the federal government free of charge. Starting this next fiscal year, however, the federal government is requiring states to pay a share. So the cost of this proposal is the state share cost to continue to access that. And then lastly, there's a proposal on increasing the Healthcare Access Fund share of medical assistance. So this proposal will increase the HCAF appropriation for MA by $25 million, and there's a corresponding decrease in the general fund appropriation for MA. So it's net neutral across both funds. Oh, I forgot about this one last. Page 153 is our technical proposal. This is really centered around moving our accounting structure to align with the new organizational changes in the department. So ensuring that our grants that are administered by one area of the department fall into that area of our budget structure and vice versa. And that is it.
Thank you. Members, we have not very much time left in our committee time. We can go over by a few minutes, but if you have an urgent question or topic that you want to bring up. And also, again, please feel free to invite the commissioner or people here today to answer your questions outside of the meeting. But Senator Edke.
Thank you, Madam Chair. And all of the things I've got, and I'll just briefly hit a couple, and they can be followed up after this is over because, yeah, the clock is getting away from us. And it's actually, first thing it also addresses our first presentation from the Department of Health, and that was the large number of new FTEs scattered throughout both proposals. These things, the additions don't go away. That creates the ongoing expense. But the one follow-up I would like is, as we look at the full budget, governor's budget here before us, we're taking savings, but the needs and services at the end, at the providers across our state don't go away. How much of what we're showing as a so-called savings is being pushed onto our local counties, our local governments? And again, you can follow up with that because there's probably more information there than we can solve in 5 minutes. So, but I would appreciate a follow-up on that because we're already hearing from our counties and what they're seeing. There's just a huge load being dumped on them, and we need to address that as we look at the full picture. So thank you.
Then we'll go to Senator Abler.
Well, thank you, and I know we got time problems. So, I don't know, this is probably your last time you'll be at the table, Commissioner, so like, Anyway, hope you enjoy the mountains or wherever you're going to wind up going, and we'll still be here. So if you have any advice along the way, you might want to send us a little note. Yeah, we're just in for a heck of a ride. And I'll not go too long, but this is a really important budget, and it serves 1.4 million people or something, and Department of Health as well. Lots of stuff. And so to you and then to your successor, I think this is a nice budget to bring forward, at least in some ways, the things you want to do, the areas you see need to be focused on. Kind of missed the plates on changes in long-term care costs and those reductions that, I don't know why we didn't talk about that, but maybe that's a different meeting. But this budget would not pass the Senate today as a standalone bill. Just so you know, there would be bipartisan opposition to it. Nothing to do with the Trump administration, nothing to do with Republican, Democrat. It has to do with making sure it actually works for Minnesota. I don't really know that Senator Utke, it's $804 million shift to the counties in this bill, which is going to go on the property tax, which is going to actually adversely affect those least able to afford their homes that we're focusing so many programs on and our DEI concern and all that. And it's going to actually lead, people will lose their homes over this. Never mind that people are going to lose services in long-term care, nursing homes, and both this budget and the other one fully funds, best I can tell, your needs for insurance and all that for the state employees. So I have great regard for. Wall says, if you're in the private sector trying to serve people, get by on reductions. We're short 50,000 workers. We talked about people stuck in hospitals. There's nothing here to get people out of hospitals. And we are going to face, Senator Mann, I agree, I don't know what's going to happen, and we're going to slog through this together. I like Nikki Haley, just so you know. But so here we are, living with the reality of the political stuff and the rest. And so I'm going to just urge your department to go back to the drawing board. And when we really start talking about real solutions, you're going to have to find a way to live within your means. And this HMO surcharge, is that based upon free federal money that's just going to keep rocketing down to us? I do have one question, Madam Chair, and then I'll be done. On page 22, there's some language you have about carrying forward unexpended non-grant operating appropriations for the second year. Can somebody at some point tell me how much money you have sitting in your mattress there that you want to carry forward? Because that's important to me too. And so you got a ton of money last time. Billion to 3-4 billion of stuff. And in that, we better find a way to manage on our own as really hard bipartisan thing. And you can tell I'm burdened by this, but that's our challenge, Madam Chair. That's something you and I could agree on to do less of to fit the targets we're going to be getting. It's never been done before. Anyway, so thank you. I appreciate that.
Senator Abler, did you want an answer to that right now, or is that, something you can answer?
I'm happy to get it offline. I don't want to, unless they know right now, but offline is fine.
Do you have that information? Ms. Bailey?
Yeah, Chair Wickland, Senator Abler, my understanding is that is an enterprise-wide proposal on the MMB side. But to your question on how much would cancel at the end of the year had we not carry over, we can do that analysis and get the numbers to you.
Thank you. Senator Bolden.
Thank you, Madam Chair. I will be brief. My question is about federal funding, given the news we're hearing this morning about the federal administration and the pause on grant funding. I think about the spaces that may impact Minnesotans in terms of SNAP and WIC and Head Start and medical assistance. Do you have a sense, or can you share your thoughts on what you are thinking, how that will affect Minnesotans, what that will mean for people?
Yeah, our CFO, Chair Wickland and Senator Bolden. Our CFO, Dave Greenman, last I saw him was out in the hall on a call trying to figure that out, and we're all trying to understand what did that mean, what does it specifically mean, what's the timing of it, and what should we be prepared to handle next. So we're right in the middle of sorting out what that was all about.
Senator Bolden? Yeah, I think any updates that you can provide to us that can help us understand what the
Absolutely.
impacts and the timeline for them would be helpful.
Sure.
Senator Port?
Thank you, Chair Wickland. Thank you for bringing this presentation. I think just to add on to that point, I'd be particularly interested in the housing stabilization area. Our nonprofit and for-profit partners are in a pretty precarious position at this moment, and seeing what those federal cuts or pauses might mean to that program, I would appreciate that.
Senator Liskey?
Thank you, Madam Chair. I'll be as brief as I can. Reading through this, I'm a chiropractor. I have a lot of knowledge on the chiropractic side of things. It's pretty disappointing that the governor's budget is pointing out cutting out chiropractic services. When we were going through COVID, the governor actually came out and expressed that chiropractic services were essential because low back pain specifically is a thing that people go to the ER for. Chiropractors treat low back pain at a significantly reduced cost than an ER would. And so cutting chiropractic services for anyone over the age of 21, we're talking about people who generally don't take care of themselves because they can't afford to. These are Medicaid patients that you're cutting these benefits from. And now you're telling them that they can't go to the local chiropractic office and pay next to nothing, which is fine. It is what it is. We agree to those rates. It's not great. They're terrible rates. But the reality of the situation is those $21 or so that it costs them to visit the chiropractor is significantly less than what it will cost that same patient to now drive to the ER and be treated for the same thing. This is not going to reduce cost. This is going to increase costs across the budget. And I don't see how that's going to solve anything at $7.5 million savings for 1 year and $11.9 million for the next. The thing about this budget is, not only did Senator Etke touch on it, we're now just passing the cost sharing somewhere else. It's not changing the budget. It's actually negatively impacting the budget, and we need to start over. So that would be my recommendation to the governor, is let's start over. Let's put a good proposal forward, and let's see what happens with that. Thank you.
Thank you. I don't have any others on the list. I really appreciate your time, Commissioner, here today. I think there is going to be a lot of discussion and a lot of work ahead of us. I agree with Senator Abler. This is a challenging time that we're going to be in. And as we get new information from the federal level that can be, that we aren't necessarily planning for at this point, that's going to impact our ability to make this budget as well. So look forward to working with your team and your successor on trying to implement a successful budget this session. And Commissioner.
Thank you. I just wanted to add that, of course, this is a very difficult time, and I appreciate there's very tough decisions ahead of us. And I just wanted to say that in all the work that we did to develop our budget, we worked as hard as we could to avoid cutting or losing services to Minnesotans and working on systemic issues where there are costs that can be adjusted to try to get down to a manageable budget. So that was our goal. That's the focus that we had as we did it, but I appreciate these are all very tough decisions.
Thank you. And members, that brings us to the conclusion of our agenda today, and we are adjourned.